slightly unworried selfie. Everybody smile. That's my room. I'm stuffed with that. Yes, we're in business.
My check.
Thank you.
Well, yes, sir.
Let's hope
Hello.
Let's hope there's more than one question after all that.
Well, thank you so much for sharing your expertise. I'm just going to say that I'm not a surgeon. I'm a cardiologist, pretend to be a surgeon this week, who I'm interested in opening an open heart program as well. And thank you for encouraging me. I am, in fact, Japanese, so hopefully that really helps. And to be honest, I don't think I've embarked on this journey if I wasn't Japanese and be able to been fortunate enough to meet Dr. Uechi when I was a resident. So, but from a cardiologist standpoint, I think we're going to be managing our post-op patients. I don't know at RVC or Florida who usually manages the post-op patient, but you can briefly talk about what it takes to, manage post-op patients and how important that is in a successful outcome. That would be great. Thank you.
Yeah, thank you for raising an important question about patient care. I think it's also important for pre-op patient to discuss the risk of complication. And what happening in University of Florida is we will just get email from the local cardiologist after the patient go home, and then we will review the record. And some dogs have a clot in the left atrium, and some dogs still have a mild regurg, moderate regurg, unfortunately. And we will provide some suggestion about, based on our experience, we should keep the anti-thrombotics in long term more than usual, or if we sometimes we recommend extensive medical therapy. So it's, but I don't think it's really changed the outcome in the long term. My impression, just like I'm a lean to the surgeon side. So to me, I think it's a more important what we do during surgery, not the post-op. But we are providing some suggestions.
Perhaps just to clarify, did you mean immediate post-surgery care, and who does that? Well, I can tell you a little bit about how things have evolved at the RBC. Maybe Masami would explain how things have evolved in Jasmine. But we've had various approaches. In 2017, we had 2 perfusion fellows, one of whom was a board-certified criticalist, and the other was a board-certified cardiologist. And so having 2 members of the team that could perform perfusion but also had a skill set in critical care and cardiology, we found very, very beneficial. Subsequently, we've lost those 2 individuals, and so at the moment, the surgery team looking after the patients in the immediate post-operative period with occasional input from critical care. We do have good cardiology support, but they're not looking after the patients during that critical, what we consider still quite critical first few hours post-surgery. So we're supervising that. I think things have evolved in Jasmine to a different level, and maybe you would speak to that.
Speak Japanese.
我々の ところでは術後のケアは、循環器科の獣医師と ICU の獣医師と看護師で見ています。
So at Jasmine, the post-op care is done by combination of cardiologist, ICU team, and also our hospital nurse.
で循環器科の獣医師は診察もしますし、手術も入りますし、でICU の術後管理もローテーションで回ってます。
And for our team in cardiology, we do many things. We do normal internal medicine, so we do consults, we go into the surgery, and then we also do ICU care.
なので手術中にどんなことが行われていて何が起こったかっていうのも分かってるし、超音波も見れるし、で ICU のところでも、その手術の後だからどんなことが起こりそうかということも分かっています。
So because we multitask, we're aware of what happens in the surgical theater, and we can also do internal medicine, so we can do echocardiogram, and also we know what would happen in the ICU because we've seen what happened in the surgical theater.
なので情報とか技術とかをシェアしているので、割と、一定の、管理ができていると思っています。
So I believe that he believes that we can sustain a good ICU care because everyone sort of shares the same experience.
Chris, anything to comment on other than you're glad TER patients don't need intensive care?
So we don't do mitral valve repairs, but we have an active open heart surgery program for congenital defects. You know, I would say that this is maybe one of the weaknesses of how we've organized it. I, for many years, was famous for sleeping in the hospital the first night. We had good critical care nurses, but our internists never really embraced what was really necessary. I mean, our criticalists. And now that has passed to Shiori, who sleeps in the hospital the first night. And so this is what I see from RVC and Jasmine is the criticalists are part of your team. And I don't think that's necessarily been the case for us. We have assumed primary responsibility for the postoperative care, which is nice in a way, but it also puts a lot of strain on the team.
We did have a criticalist in the team, and we will have a criticalist in the team in the future, but one of the frustrations we had was actually convincing a criticalist to engage, and I know that you've had that difficulty. Post-operative care for especially mitral valve patients, you can't just walk into a care of a patient like that and not understand some of the unique things that happen as a result of the process of cardiopulmonary bypass and so on. So it's really nice when a criticalist engages with that process, and it makes a massive, massive difference. Just FYI, I also used to sleep in the hospital, and we had the British Broadcasting Company decided to do a little documentary on the Royal Veterinary College, and they insisted on coming and filming me through my office door, rolling a bed mat out and a sleeping bag, just to prove that I did actually stay in the hospital overnight. Got several interesting propositions as a result of that from people watching the television. Yeah. Any other questions?
Dogs are notoriously bad at tolerating cardiopulmonary bypass, but nobody has mentioned the bleeding issues that occur. In fact, Orton and Dr, that was one of the early human people, he said open heart surgery almost didn't happen in people because they used the dog as the model, and I haven't heard any mention of that, post-operative issues, bleeding issues, what you've done to maybe make it go away. I mean, they don't tolerate the pump, period. And I was doing open heart surgery in the 70s at CSU with hypothermia. And with deep hypothermia, you get an hour of operating time safely. And I doubt your procedures take that long. So where does it fit in? Am I just too old to know any better?
It's a great question, and there's no question that dogs following a run on bypass in our hospital at least have a tendency to bleed despite what we consider on the basis of ACT as complete reversal of the heparin that we've used during the pump run. Obviously we all know how insensitive ACT is for really properly tracking coagulation. We haven't found anything better. We used thromboelastography and all sorts to try and better characterize it. So they do, and I think Chris coined the phrase to me years ago about this sort of almost biologic bleeding rather than, but they do have a tendency to bleed. Interestingly, when I've seen surgery being done in Jasmine, the bleeding is a lot less than we experience. The reason or explanation for that, I don't fully understand, but it's used, so compared with a normal dog thoracotomy or thoracic surgery patient, they bleed. But usually for us, with the protocol that we use, that bleeding is pretty much done by about 7 o'clock in the evening. And these are dogs that are having surgery 9 o'clock in the morning, hitting ICU somewhere around 1 o'clock. So unless there's something really wrong, by the early evening that bleeding has abated. We have a very good transfusion medicine team, and we transfuse exogenous blood. I think Masami has a much less demand on blood donation programs for a variety of reasons, and I don't know, maybe that makes the difference, but I'll let him comment on that.
術後の出血を減らすには手術の開始のところから始まってます。
So his plan of reducing the amount of bleeding starts from the beginning of the surgery.
特にヘパリンを入れる前にいかに出血を少なくしていくかが課題です。
So before we heparinize the patient, we have to reduce the chance of bleeding.
なので、ガーゼを1枚ぐらいしか使わないぐらいで、開胸まで持っていくのが良いと思っています。
So I tend to coagulate when we do a thoracotomy by just using one single gauze to wipe out any bleeding.
なので、電気メスをよく使います。
So I use a lot of electrocautery.
で、動脈の剥離とかは特に注意はしますけども、これも同じ理屈でやります。
So same careful attention is paid when I dissect the fat around the aorta.
このことに気をつけないでヘパリンを入れると悪夢が待ってます。
And if you're not careful enough and then you heparinize the patient, a nightmare is waiting for you.
もう出血が止まりません。
And the bleeding cannot be stopped.
なので、最初にきちんと止めるのが基本です。
So the preventive measures are very important.
それで大動脈にカテーテルを入れたり、左心房を切ったりしますので、ここは大きな出血点になります。
And the major point of bleeding site are the cannulation site on the aorta and the incision site of the left atrium.
特に大動脈は、致命的なダメージを受ける可能性があります。
And especially we have to be careful on the aorta because it could be life-threatening.
なので大動脈に糸をかけるときには、内腔に貫通しないように血管の中を通すようにします。
So when we place stage sutures on the aorta for the cannulation, I make sure that the needle doesn't go through the vessel.
それで出血が減らせます。
And that way I can prevent the chances of a hemorrhage.
でそこにカテーテルを入れますが、カテーテルを抜くときもポイントがあります。
And we place the cannula, and there is also a technique for removing the cannula.
大動脈の血圧が高いと、糸を締めてもなかなか閉じません。
So when you're trying to remove the cannula and the patient blood pressure is high, and sometimes the bleeding cannot be stopped.
なので皆さんが驚くほど血圧を下げます。
So what I do is I reduce the blood pressure temporarily, and you'll be shocked how low I lower the blood pressure for the patient.
収縮期で30ミリマーキュリーぐらいになることもあります。
I reduce it down to systolic 30 millimeter mercury.
そこでしっかり締めて、それから血圧をすぐ上げます。
So I reduce the blood pressure, I tie off, and then I'll increase back the pressure.
それで出血のアクシデントは減らせます。
And that way we can prevent the chances of bleeding.
でもし出血が続く場合は同じように血圧を下げて縫ってあげるということを繰り返していきます。
And if I see any signs of bleeding at the aortic site, I do the same. Lower the blood pressure and then tie it off or do a suture. And then after the suture is complete, then I'll raise back the blood pressure.
これで大動脈は大体、抑えることができます。
And that way I can prevent the bleeding from the aortic site.
で、左心房はもっと難しいです。
And left atrium is another story.
ステージ D になると左心房の壁は薄くなってます。
So for stage D advanced patients, the wall of the left atrium becomes very thin.
針の太さと同じぐらいになっている時があります。
Sometimes the thickness of the atrial wall is as thin as the needle.
そうすると針を入れるだけで針穴から出血をします。
So even if you're just threading the needle through, the blood comes out from the needle site.
なのでこれを抑えるには左心房を張らせないボリュームを抑えることが大事です。
So to prevent that from happening, make sure that the heart doesn't get enlarged so that the pressure inside the heart doesn't increase.
なので心臓が動く前に左心房を縫い上げてしまうか、
So to prevent that, I start stitching up the left atrium before the heart starts beating again.
心臓が動いている時に縫う場合は、ボリュームを減らします。
And if I'm stitching up the left atrium, once the heart is already started to move, I tend to lower the blood pressure and reduce the volume.
針穴から出血している場合は、そういうことで血圧が低めの50ミリマーキュリーぐらいになる時もあります。
And when I lower the blood pressure, it becomes systolic of about 50.
なので出血する可能性を減らすためにボリュームを減らす、血圧を下げる、その間に縫うというのがポイントです。
So my technique would be to lower the blood pressure and also to lower the volume inside the heart chamber, and then I'll finish up the stitch.
これでヘパリンが入ってても平気だったりします。
And that way, even the patient is heparinized, most of the time it's okay.
Thank you. Thank you. It's been a fascinating afternoon. It makes me want to be 20 years old so I can do this.
Does anyone have anything else to add to that discussion before we take one last question?
I have just one point for the breathing. If we use a big circuit, that will dilute the blood more, and that will reduce the coagulation factor, and that will be another reason, like an institutional difference, I guess.
Certainly is. I know our prime volume is much greater than Masami's. I don't know what prime volume is. Chris?
Tim, you're absolutely right. There's no way to avoid a degree of coagulopathy, a degree of platelet dysfunction. It's part of cardiopulmonary bypass, but it's probably not correct to say that it cannot be managed. So there's a variety of things you can do. The meticulous surgical technique is very important. You don't want what I would term surgical bleeding. but there's inevitable degree of biological bleeding that's going to occur. So different things you can do. What we do, we always give some fresh whole blood. Fresh whole blood has active functional platelets. That is helpful. I don't know what you're doing with your aminocaproic acid, but we are now continuing that. We give that during the bypass run, and we continue it into the postoperative period. That seems to be helping recently. And we have a cell washer to where if they're shedding too much blood, we will run that through the cell washer. And as Dan has alluded to, at some point that biological bleeding will begin to subside if you can manage to get through that couple of hours where it seems like the bleeding is too much. So these are all, bleeding is part of it, but I think part of the team that learns how to manage it.
Thank you, guys. Dominic, do you have a question?
Yes, looks like Japanese, but from Korea, not from North. Yes. In my open surgery program, sometimes it will be severe hemolysis occurs. So, have you ever encountered cases where the hemolysis occur during surgery and requires some treatment?
Who wants to address the problem of hemolysis following?
チェックしてほしいのは自己心肺のそうオクルージョンの締め方をチェックした方がいいかもしれません。
What he says that one thing I want you to check is on your bypass machine. You should have a roller pump. Check how much occlusion you guys apply.
締めすぎると血球が壊れます。
And if you make it too tight, you tend to cause hemolysis.
あともう一つは、術中にサクションを使っていると思うんですが、
And I know when you do the surgery, use a suction.
サクションの陰圧の圧が強すぎる場合も血球壊れます。
And if you use high pressure to suck out the blood, it also causes hemolysis.
この2点を、チェックすると、もしかしたらいいかもしれません。
Maybe you can look into these 2 points.
他にもあるかもしれません。
I think it's pretty much it. And to decrease the suction amount, it's good to have additional cannula from right atrium sometimes. That will help reducing the blood coming from the primary vein. But yeah, I think it's pretty similar to Dr. Uechi's.
ありがとうございます、先生。
Well, I hope you'll agree with me. That's been a pretty fascinating afternoon. I've got one last thing to say, and I know I'm supposed to say this right at the beginning, but I have no conflicts to declare other than the conflicts in my own mind. So thank you all for coming along. Any of us, I'm sure, will be happy to hang around and talk further with you, but officially it's a wrap. So thank you very much.
Thank you.